So today we will be starting with the atrial fibrillation. Now we have 3 ECGs, 4 ECG in front. So we all know that if on ECG we see a irregular ventricular rate or irregular rhythm, we say that it is an atrial fibrillation. But how we have to go about it, because there are other rhythms, like example atrial flutter with a variable AV block, then multifocal atrial tachycardia. They also sometimes present with variable rate. So how to differentiate these with atrial fibrillation? This is our first thing. So whenever you have a variable rhythm, there can be three things. First is the atrial fibrillation. Second can be atrial flutter. Third can be MAT. MAT is multifocal atrial tachycardia. Okay. Please remember that atrial flutter is generally, the rate is constant. It is not variable. But atrial flutter with variable AV block has a irregular rhythm. I am again repeating that atrial flutter generally you will have a regular rate, that is RR interval will be constant. But when atrial flutter with variable AV block, then it will be having irregular rhythm, that is variable RR rate. So how to differentiate? Please remember, in case of multifocal atrial tachycardia, you will get P waves, and there are more than or equal to 3 morphology of P wave. This is the first point. So in multifocal atrial tachycardia, you will get P waves, and these P wave will have a different morphology, more than 3. In atrial flutter, you will also get P wave. But please remember, the pattern is always same. Pattern is same. You have to remember this point. Pattern is same. What is the pattern? I'll tell you. For example, if you see this ECG, the rate is variable, RR is not constant. So most of the people will say that it is an atrial fibrillation, but it is not atrial fibrillation. See, you are getting P wave. But if you see, now rhythm is irregular, you are getting P waves. So it may be atrial, because in atrial fibrillation you can also get sometimes P waves. So how will you differentiate? Now you have to see the pattern. But where you will see the pattern? Pattern will be seen between those RR interval where RR interval is same. For example, here and here the RR interval is same. In these two places, RR interval is same, and if you see the pattern is same. Whereas if you will compare and contrast it with the atrial fibrillation, you will never see same pattern like this. So whenever you have irregular rhythm, take 2 RR interval where the rate is constant, that is RR interval is same, and check the pattern. If the pattern is same, just like here, then it will be a atrial flutter. And if this pattern was different, then it would have been atrial fibrillation. Okay. Now coming to this ECG. Now if we take V1 lead, now V1 lead, you are seeing that RR interval is not constant. RR interval is changing. So now it can be 3 things: atrial flutter, multifocal atrial tachycardia, or it can be atrial fibrillation. Now how to differentiate? First you will take those RR interval where those RR interval which are constant. For example, if you take this RR interval, this and this, so RR interval are more or less constant. And if you see the pattern, pattern is not same. See, here the P waves are seen differently, and here the P waves are differently, as compared to the previous ECG in atrial flutter, where you were seeing the same pattern. So this is a very important technique. When you see irregular rate, take those RR interval where take those two RR interval which are constant and see the pattern. If the pattern is same, then it is atrial flutter. If the pattern is different, so this is a case of atrial fibrillation. So this is how you have to differentiate between atrial fibrillation and atrial flutter. And I am again telling you that atrial flutter generally present with the constant rate. Okay. Now if you see this ECG here you can see that rhythm is not regular, but you can see different types of P wave. Which morphology of this P wave, morphology of this P wave, morphology of this P wave, morphology of this P wave. It is different. So if you see more than 3 or different morphology of P wave, you see it is a multifocal atrial tachycardia. So this is how, whenever you are given an irregular rhythm, you can easily differentiate. So this is the point that I wanted to highlight, that how to differentiate between atrial fibrillation and atrial flutter. So now you have to understand that pattern is same means atrial flutter. So how to see the pattern? You have to see the pattern between the same, where the RR interval is same. Although the RR interval is different, that it is not constant, but there are certain places where you will see same RR interval or more or less same RR interval. So you have to compare at that point. So you will see that if the pattern is different, it is atrial fibrillation. If the pattern is same, it is atrial flutter. So now you have diagnosed the patient with the atrial fibrillation. So once you have diagnosed that this is a case of atrial fibrillation, you have to know what is the cause of atrial fibrillation. So there are multiple causes of atrial fibrillation. If you see the causes of atrial, first we have to understand what is the pathology of atrial fibrillation. So if this is your right atrium and this is your left atrium, this is your left atrium and this is your right atrium, there are multiple areas where automaticity can develop, which can start firing, and SA node is suppressed. So when they start firing, they can fire at a rate of 300 to 600. Please remember that it can fire at a rate of 600. And when these depolarization waves through AV node reaches ventricle, they also start firing at a higher rate. So in atrial fibrillation, generally we see a ventricular tachycardia because atrial is firing at a high rate. Some of those depolarization wave reaches AV node, and they are because of AV nodal delay, some are not able to cross AV node, but some of them crosses. So we always see a ventricular tachycardia, but the ventricular rate is never more than the atrial rate because the point of origin is atrium, and some of the atrial depolarization wave are not able to pass the AV node. So ventricular rate is always, so ventricular rate is always more than the atrial rate. Now, can we have a ventricular rate can be less than 100? Yes, even ventricular rate can be less than 100. If there is if the patient is having a AV nodal blocking drug, or if the AV node is not functioning properly, then atrial impulses cannot reach the ventricle, and ventricle can fire at a rate of 70-80. So there are a lot of atrial fibrillation case where ventricle is contracting at a normal rate, but in most of the cases ventricle will contract at a higher rate, that is more than 100. Therefore we take it as a tachyarrhythmia. We read atrial fibrillation and tachyarrhythmias. Now there are a lot of places where automaticity can develop, reentrant circuit can develop, and they can fire. The exact mechanism is not known, but there are 4 places which we have to remember. Although any part of atrium can fire, but there are 4 areas. One is the area around pulmonary vein. So area around pulmonary vein. Second, there is a remnant of vein of Marshall. Vein of Marshall is present in embryo, and it drain into great cardiac vein, but it is not present in adult. So at this area, automaticity can develop. Automaticity can also develop in the sleeves of SVC. The area, that is the area where SVC join the right atrium, plus any previous scar around any previous scar. Okay, these are the areas where you can see the automaticity. Now, what can be the causes? The causes, please remember, if there is anything which there is high adrenaline in the body, for example, pheochromocytoma, in cases of pheochromocytoma, in case of anxiety, adrenaline infusion, which is particularly used in cases of ICU. Most common arrhythmia in ICU after sinus tachyarrhythmia is atrial fibrillation. Therefore, if people who are working in ICU, they have to know the management of atrial fibrillation, that we will discuss in detail. Then anxiety, adrenaline, then pheochromocytoma, anxiety, adrenaline infusion, patient of sepsis, old age, obesity, OSA, obstructive sleep apnea, HA, hypopnea syndrome, that is obstructive sleep apnea, hypopnea syndrome. Then any condition where left atrium or right atrium is enlarged. Example, mitral stenosis. And especially remember that atrial fibrillation associated with mitral stenosis is known as valvular AF. Then right atrial enlargement can be seen in pulmonary artery hypertension. So these are the conditions where you can see atrial, plus thyrotoxicosis. In thyrotoxicosis, again, most common arrhythmia in thyrotoxicosis after sinus tachycardia is atrial fibrillation. Then in patients of diabetes mellitus, hypertension, SLE, amyloidosis, sarcoidosis. So these are the causes of atrial fibrillation, but generally in most of the cases it's very difficult to find out the cause, but this is the list. There are other causes, but you have to remember these main causes. Now, so you have diagnosed the atrial fibrillation, you have known the causes. Now, how will you do the treatment? So for treatment point, you have to divide the atrial fibrillation into two parts, whether is it acute or it is chronic. Acute, that is means atrial fibrillation which has come before 48 hours, and chronic which has come after 48 hours. Acute, that is within 48 hours, and chronic after 48 hours. Now, why this 48 hour has been chosen? There is a logic behind it. For example, if this is your left atrium and this is your left ventricle, this is your left atrium, this is your left ventricle. So what happened in most of the studies, initially it was found that within 48 hours, now first understand, in atrial fibrillation, there is not proper atrial contraction. They are just doing like this. They are not contracting. So they are fibrillating. So there is stagnant, blood is stagnant there. And when blood is stagnant, it can form clots. So there are high chances that in atrial fibrillation, in left atrium or right atrium, clot can be formed. So it has been seen in most of the cases that within 48 hours, clot is not formed. And clot formation generally takes 48 hours. Therefore, this acute and chronic classification has been done on the basis of clot formation and on the basis of experimental studies that within 48 hours clot is not formed. So the management is different, because there is also a separate classification, pathological classification and other classification. But when you are doing management, then this classification is best because it is based on experimental studies. So if within 48 hours clot is not formed, so we take it as an acute atrial fibrillation and the treatment is different. And after 48 hour clot is formed, so we take it a chronic atrial fibrillation and the management is different. So now, if there is an acute atrial fibrillation, so we know that clot is not, we consider that clot is not formed. Okay. Now, if we don't know the duration of this atrial fibrillation, then we take it as a chronic. So chronic is taken more than 48 hours or unknown duration. Unknown duration, because we don't know the duration. Now, if it is an acute atrial fibrillation, we see whether patient is in shock or not. If the patient is in shock, we do cardioversion. What is cardioversion? Cardioversion is simply conversion of non-sinus rhythm. We know that in atrial fibrillation, the SA node is the rhythm are coming from the atria, and whenever the rhythm is not coming from the SA node, it is known as non-sinus rhythm. So conversion of non-sinus rhythm to sinus rhythm, this process is known as cardioversion. Now you can do cardioversion by two methods. Either you can use the paddles, you can put one paddle on the right side below the clavicle and the second paddle you can keep here in the fifth intercostal space. This is one of the method, and you can do, and you can use a synchronized energy of 200 joule and you can give shock. That is one way. Second, if the patient is very obese, or especially in cases of the female, you can keep one pad over the sternum slightly on the left side and other just behind, and you can do electrocardiogram. So these are the two position of the pad. So you put pads. I have told you the positions of the pad. Then this pad is connected to the cardioversion, that is defibrillator, or the defibrillator of the cardioversion machine, and you synchronize it. Synchronize means that shock will be delivered only at the time of R wave. So if this is your atrial fibrillation, you synchronize, so a arrow start coming over the R wave. So whenever you will give the shock will be delivered to the patient at the time of R wave. So this is known as synchronized, this is known as cardioversion. So you give a synchronized energy of 200 joules. So this is known as a electrocardioversion. This is known as electrocardioversion. Electrocardioversion, where you connect the pad to the patient and that pad is connected through the wires to the defibrillator machine, and you give a 200 joule of energy to the patient in a synchronized way, synchronized with the RR interval, R wave. And I have told you the position. There are two positions, one on the right side just below the clavicle, and on the left side in the fifth intercostal space. And if the patient is very obese, or in case of the females, you can put the pad over the sternum slightly on the left side and second pad on the left side just opposite to the first pad. So this is a way of electrocardioversion. And second is chemical cardioversion. Chemical cardioversion you can do with the help of two drugs. One is amiodarone and the second drug is ebutylide. Please remember, ebutylide cannot be used if the ejection fraction is low, or if the patient has ischemic heart disease or coronary ischemia. Therefore, in most of the places, especially in India, the drug that is used is amiodarone. Amiodarone is used in most of the cases, ebutylide is not. Although it is mentioned in ebutylide can also be used, but most of the cases, because amiodarone can be used in patient with low ejection fraction, and even in the patient of ischemic heart disease, amiodarone can be used. We'll come to these drugs later. Now, so after doing cardioversion, we'll also, this is first thing that we will give cardioversion if the patient is shocked. Second is we will start anticoagulant. We will discuss about which anticoagulant to be used and what. And the third thing is we will control ventricular rate. We will control the ventricular rate. So we have to do, if the patient is in the shock, well, we have to do cardioversion. We can do electrocardioversion and chemical, but the best is electrocardioversion. And we can also do chemical cardioversion. Then we have also start anticoagulation, that is we start simultaneously. And then third point is we have to control the ventricular rate. These three things are very important. Now, if the patient is not in the shock, then what we have to do? If the shock is absent, then we have to control. We will start the patient on anticoagulant. We will control ventricular rate, and now we will do cardioversion. But here cardioversion, please remember, chemical cardioversion can be first tried, then electro. Generally there is no need of electrocardioversion. So this is the different how to manage with acute atrial fibrillation. Now coming to these drugs which is required in case of amiodarone and ebutalide. See, both of these drugs, how mechanism, first see how they convert a non-sinus rhythm to the sinus rhythm. We know that if we see the action potential graph, it is like this. This is the zero phase where sodium comes inside the cell. Then this is the first phase where potassium goes outside the cell. Then there is second phase where potassium goes outside the cell and calcium comes inside. This is the second phase. Then in the third phase, what happens, that potassium remains open and there is repolarization starts, and then this is the third phase, and here calcium channels are closed, and then there is the fourth phase which is the baseline. Now please remember, in the first phase, the potassium channel which are opening, these potassium channels are called as ITO. Okay. Then in the second phase, the potassium channel which are opening, these are known as IKR. Only 20% of the IKR opened in the second phase and the rest open in the third phase, IKR. And these IKR are known as delayed rectifier potassium channel. Then after this, there is a third potassium channel that is known as IKL. They also open after phase 3, and these are known as inward rectifier potassium channel. Okay, so ebutalide, and so if we talk of ebutalide or amiodarone, they block this IKR, that is delayed rectifier potassium channel, which mainly open in the third phase and some also open in the second phase. Okay, so when calcium channel stops, most of the delayed rectifier potassium channel opens, but 20% are also open along with the calcium. Calcium. So if you are asked amiodarone or ebutalide blocks which channel, you have to answer it is a delayed rectifier potassium channel. So when delayed rectifier potassium channel are closed because they block, so action potential duration is increased. Now the action potential duration is like this. So when action potential duration has increased, we know that during action potential duration, cell cannot be activated, cell cannot be depolarized, or we can say that simply cell is in inactive phase. So when the cell is in inactive phase, the inactive phase of the cell is increased. So all those reentrant circuit, all those areas which have developed automaticity are not able to fire at those areas. Then at that time, SA node gets the time to increase its automaticity, or it gets time to fire. So when these drugs are used slowly and slowly, it doesn't happen in acute phase. Slowly it takes hours to days that non-sinus rhythm is converted to the sinus rhythm. Reason being, most of the cell goes into the refractory phase, and these automatic areas which have developed automatism goes into the refractory phase, and SA node start firing. Okay, but it's not necessary that these drugs, because these drugs, it's not possible that it always works. Okay, so there are some of the atrial fibrillation which are refractory to the drugs. We say those atrial fibrillation are refractory to the drugs. Now this is the mechanism how amiodarone or ibutylide works. See, ibutylide it comes in a vial where it is present is 10 mg in 1 ml, and dose of ibutylide, if the patient is less than 60 kg, the dose is 0.01 mg per kg over 10 minutes, and you can repeat after 10 minutes. So example, if the person is of 40 kg, the dose will be 0.01 into 40, that is 4 mg. That you have to give over 10 minutes. And if the person doesn't respond, you can repeat after 10 minutes. So this is ibutylide, but please remember it cannot be used in patient of coronary artery disease or reduced ejection fraction. Now coming to the amiodarone, the dose of amiodarone, most of the people must be knowing, it is 150 mg loading dose over 10 minutes, followed by 60 mg per hour, or you can say 1 mg per minute for 6 hours, followed by 30 mg per hour or 0.5 mg per minute for 18 hours. And then you can take it on oral, patient on oral amiodarone, where dose is 200 to 800 mg daily, but in 3 or 4 divided doses. Okay, so this is how amiodarone works. This I have told you about the treatment. Now, but please remember, when in India we are using amiodarone, in ICUs we are using amiodarone. What are the side effects? We have to know about the side effects of the amiodarone. So amiodarone side effects are of two types. One, that can happen on a single dose. So there are 5 side effects which can happen just on a single dose. What are they? They are bradycardia, hypotension, thrombophlebitis. Therefore, it is always said that you have to give amiodarone with the center line, and if its center line is not present, you have to be very cautious. You have to take at least 2 different cannula. You have to give amiodarone through one cannula, and after some time you have to give through the different cannula. And it's always better to give amiodarone through the center line, because it can cause thrombophlebitis. Fourth, it can cause long QT syndrome. Any drug which blocks potassium, delayed rectifier potassium channel, can cause long QT syndrome. And one more side effect, deranged LFT. So please remember, a single dose of amiodarone can cause a deranged LFT. Now, long QT syndrome, normal QT syndrome, it is less than 440 in males and less than 416 cases of females. So if it is more than 416 female or more than 414 males, then it is called as a long QT syndrome. If it is more than 500, then it can develop long QT syndrome. And if the QT interval is less than 350 milliseconds, then it is called as short QT syndrome. We will discuss QT syndrome in some other lecture of the ECG series. So, if the patient has a long QT, now amiodarone can cause long QT syndrome. Please remember, amiodarone IV amiodarone can cause long QT syndrome, but oral amiodarone doesn't cause long QT syndrome. Therefore, in Japanese guideline, if you will read, they never give amiodarone IV. They always use it orally. They do electrocardioversion and use it orally. But in India, we धड़ल्ले से use हो रही है. We are using amiodarone. Okay, so these are on a single dose. Then it can cause bradycardia, hypotenuse, thrombophlebitis, and derange LFT. Now, on chronic use in neurology, when you are giving on amiodarone as a chronically oral dosing, patient complain of visual halos, photophobia. Patient can also develop optic neuritis. In some patient can develop ataxia and rarely quadriplegia. But yes, amiodarone can develop quadriplegia. Okay, so these are neuro and eye complication. Then if you come to the lungs, there are 4 things that amiodarone can cause. It can cause organizing pneumonia. The exact mechanism how it causes an organizing pneumonia is not known, but it can cause organizing pneumonia, pleural effusion, ARDS, and alveolar hemorrhages. So when amiodarone causes lung toxicity, there is no pathognomic sign. But the best part is that the treatment can be done with the help of steroids. Steroids are wonderful drugs which can be used as a curative management in cases of lung toxicity of amiodarone. So a baseline X-ray, chest X-ray, is always indicated before starting amiodarone therapy, and the guidelines say every year you have to do a chest X-ray. This is the guideline. Okay. Then endocrine, it can cause hypo as well as hyper, both kind of thyroidism. It can cause hyperthyroidism as well as hypothyroidism. It causes hypothyroidism because it prevents T4 to T3 conversion, just like propanol, steroids, and it causes hyperthyroidism because it contains iodine, therefore it can cause hyperthyroidism also. But please remember, the incidence of hypothyroidism is very high, around 16 times more than the hyperthyroidism. Okay, so how will you treat a hypothyroidism? You will give levothyroxine, which is actually T4, and in a hyperthyroidism you will give carbimazole or PTU, that is propylthiouracil. And therefore a baseline thyroid function test is mandatory before starting amiodarone, and guidelines say thyroid function test has to be repeated 6 monthly. Just like X-ray has to be repeated every per annum, that is every yearly, simply thyroid function test has to be done 6 monthly. It can also cause erectile dysfunction. And on skin, it can cause blue color discoloration. and that is known as I'm not able to remember, Smurf sign. Smurf sign. So it can Smurf sign, that is blue color discoloration on this. So these are the side effects of amiodarone which you should know, because whenever you are starting amiodarone, you should know that which are the baseline things that you have to do. Now we have second thing we have, now this we have known. Now we have seen the treatment in cases of the acute fibrillation. Now what you will do in case of chronic atrial fibrillation? Chronic atrial fibrillation. Acute chronic atrial fibrillation, that is more than 48 hour or unknown duration. Now here we have to understand that do we have TEE facility, that is the trans echocardiography facility, trans thoracic echocardiographic facility. So if we are not having trans thoracic echocardiographic facility, then we will follow a rule that is known as 3C4 rule, because we cannot rely on abdominal or transthoracic echocardiography to look for the atrial thrombus, because smaller atrial thrombus are generally not seen by the transthoracic echocardiography. For them, we have to have TEE facility. And if we will miss the thrombus and we will convert the patient into the sinus rhythm, then that thrombus can go to the left ventricle, and from there it can go to the brain and it can cause ischemic stroke. So this is the problem in case of the chronic atrial fibrillation treatment. We have to know that this patient is having a clot or not in the left or right atrium, and that we can know just by the TEE, because with the thoracic echocardiography the sensitivity and specificity is not that high, and a lot of smaller thrombus are missed, and those thrombus can go to the brain and can cause clot. Therefore, if we are not having TEE, that means we cannot know that this patient has a clot. So what we will do, first for the 3 weeks you will anticoagulate this patient. We will see in detail which anticoagulant we'll use, and then after 3 weeks you will do cardioversion, and then you will also give anticoagulant for 4 more weeks. We will give anticoagulants for 4 more weeks. Now you can ask a question that if you have given anticoagulant for 3 weeks and then we have done the cardioversion, and after doing the cardioversion the rhythm has converted to the sinus, then now why will anticoagulate the patient for more? So I will answer this question after just 5 minutes. Okay, so this is when we don't have a facility of TE. If we have a facility of TE, we will start anticoagulation, then we will do TE. If T show the clot, then we will again follow this 3C4 method, that is we will start anticoagulation for 3 weeks, then we will do cardioversion, and then we will anticoagulate. If there is no clot, we will do cardioversion and then 4 weeks of anticoagulation. Okay, now you can ask that now you have done TE, there is no clot, you have done the cardioversion, then why you are giving anticoagulation for 4 more weeks? Because there is no clot and the rhythm has already converted the sinus rhythm. So why you are giving anticoagulant and you are increasing the risk of bleeding in patient? So please remember, Harrison says that even when the non-sinus rhythm is converted to the sinus rhythm, even after weeks, there are chances of formation of clots. Therefore, it is recommended that even after the cardioversion, when the non-sinus rhythm is converted into the sinus rhythm, you have to give anticoagulation for 4 more weeks. Okay, because there is chances that even after the sinus rhythm has been developed, their clot can be formed. Okay, so this we have seen. Now, what about the ventricular rate? Second, we have seen that I have written a lot of areas that we have to uh, control the ventricular rate. Ventricular rate. So why we are so obsessed with controlling the ventricular rate? Please remember, since the ventricular rate is high, so diastole time is low. So left ventricular filling is low. So ejection fraction is low because of the Starling law, and cardiac output is low. So patient will have symptoms. So if we'll decrease this ventricular rate, diastolic timing will increase, left ventricle filling will increase, ejection fraction will increase, cardiac output will increase, and symptom will decrease. That is why ventricular rate are very important to decrease or to control. Okay, we have taken care of the uh, atrial automaticity. We have converted it to the sinus rhythm, but patient will not get symptomatic relief until and unless we will do this. We will control the ventricular rate. So for controlling the ventricular rate, and if this ventricular rate is not controlled, patient can develop a very important thing that is known as TIC, tachycardia induced cardiomyopathy, and this patient can also develop in, can land up into CHF. Therefore, it is very important to control the ventricular rate. So, how we will control the? What is the guideline? It is said that it should be less than 80 at rest and less than 100 on light work like walking. But this is very difficult to achieve. So there is also something known by the name of acceptable heart rate. This is mentioned in the Harrison. Acceptable heart rate is less than 110. So this is the thing. Now how will you do? We have beta blocker. If beta blocker is not you cannot give beta blocker. For example, in case of asthma, if there is contraindication of beta blocker, you can use calcium channel blocker. Third, you can use digoxin. Now there is important point regarding digoxin. Initially, the patient with reduced ejection fraction or patient with chronic heart failure were given digoxin. But recent studies, Harrison mentioned this, that recent studies have shown that using of digoxin in controlling of ventricular rate increases mortality. So I am again repeating that using of digoxin in control of ventricular rate in atrial fibrillation had increased the mortality. Therefore, its use has declined. This is the exact line from the Harrison. And there is fourth technique when all these things doesn't work, that is known as ablate and pace therapy. This is a very good technique. What happened in this? For example, if this is your heart, this is left atrium, right ventricle, left ventricle, and this is the AV node. So what happened? That ablation of AV node is done. That is, AV node is deployed to radio frequency ablation. AV node is destroyed, and a ventricular pacing is done in the right ventricle. So now a pacemaker is now being pacing of right ventricle is done. This is a pacemaker, and pacing of right ventricle is done. So now this is the only condition. Now it is atrial is now under the SA node, and none of the depolarizing wave of SA node is coming to the ventricle, and ventricle is depolarizing along because with the help of pacemaker. So ventricular rate is pacemaker dependent. So this is the catheter. There is the ablate and pace therapy where we ablate the AV node and pace the ventricle with the help of the pacemaker, and ventricle contraction is dependent on the pacemaker. So this ablate and pace therapy is only used when other beta blocker, calcium channel blocker therapy, we are not able to control the ventricle rate with the help of beta blocker or the calcium channel blocker. So this is the about the ventricle rate. Now third point is regarding the anticoagulants. Now anticoagulants, we can use a lot of anticoagulants. We all know that vitamin K antagonist, that is warfarin. It has been used since time immemorial. Then other is antithrombin 3 inhibitor, that is dabigatran, and there is also oral 10A inhibitors like rivaroxaban, apixaban and edoxaban. Okay, these are the anticoagulants which you can use. Now, which to use and which not to use? Please remember, if the patient is having valvular AF, that means AF is because of the mitral stenosis, or the patient is having mechanical valve. So in these cases, the best anticoagulant is warfarin. So studies have found that warfarin is best. So here you have to use warfarin. In other non-valvular AF, in non-mechanical valve AF, you can use any of these. But most of the people are using rivaroxaban or apixaban. The problem with warfarin is, there are three important problems with the warfarin. That warfarin takes time, because when we give warfarin, we have to maintain INR of 2 to 3 to prevent development of clot. So warfarin takes around 5 to 6 days to reach to that point. So it takes time. Secondly, when the patient is on warfarin, we have to continuously monitor the patient, because there are chances when INR can be raised. So we have to decrease the dose of warfarin. There are chances when INR is decreased, so we have to increase the dose of warfarin. So we have to continuously check the warfarin. And third, warfarin has a lot of interaction with the food and the other drugs. So all these points are not seen with these new oral 10A inhibitors like rivaroxaban. Okay, when the patient is on the rivaroxaban, you don't have to measure INR. It very quickly, swiftly attain the value of anticoagulation which is needed to prevent clot. So these are the positive point. But the negative point is that warfarin can be used even in the patient of CKD, ESRD, when the creatinine clearance is less than 15. But these are avoided because they are not safe in cases of the chronic kidney disease. But if I ask you, out of these rivaroxaban, apixaban and edoxaban, which is the safest and most studies, which has come out as the safest drug which can be used if creatinine clearance is less than 15, then answer will be apixaban. Okay, so this is what I have to understand. Now, when you are using these drugs, initially when rivaroxaban was released, so most of the pharma company were saying that it never caused bleeding, like warfarin. Why people started mainly using rivaroxaban? Because the pharmacology companies have created an havoc that it never caused bleeding. But a lot of massive bleeding have taken place because of the rivaroxaban, and even a lot of patients have died who are taking rivaroxaban. So this is also the case. Now, how to reverse the effect of warfarin? The warfarin effect you can reverse with the help of vitamin K, FFP or prothrombin concentrate. Now also, initially there was no reversible drug for these newer anticoagulants, but as the news of bleeding because of these drugs have started coming, there are also reversible drugs which can reverse their effect have also been found. For example, rivaroxaban and episaban. Its effect can be reversed with the help of ND-hexanet alpha. So ND-hexanet alpha can reverse its effects. If you want to reverse the effect of dabigatran, there is a monoclonal antibody by the name of IDARUCIZUMAB, that is idarucizumab. Okay, so you can remember idarucizumab. So this can be used. Now rivaroxaban bleeding can be reversed with the help of ND and hexa alpha. Okay, ND hexanet alpha. So there are proper dosing regime. If you want, what is the ND and hexa alpha? We give a dose of 400 mg loading dose at a rate of 30 mg. If you want, you can remember this, 30 mg per minute, and then followed by 4 mg per minute over 2 hours. 100 mg powder of NDX alpha comes, which has to be diluted in 10 ml. So we get a concentration of 10 mg per ml. So initially for 400 mg loading dose, we have to give 4 vials. So this is the thing. Now very important thing is that in atrial fibrillation, you can develop clots which can cause ischemic strokes. This is very important for. So how will you decide that which patient you have to anticoagulant or which you don't have to anticoagulate on a clonic basis? So for that, there is a criteria that is known as Chad's-Vass criteria, where this A is given 2 points, this S is given 2 points, rest of them is given 1 point. Now what are these things? Chad's-Vass. This C is for CHF. If the patient has CHF, you have to give 1 point. This H is for hypertension. This A is, which is given 2 points. This is for age that is more than 75 years. This D is for diabetes mellitus. This S, which is given 2 points, is for earlier stroke or earlier trans ischemic stroke attack. This one is for vasculitis. This A is again for age, but here the cutoff point is 65. And this S is for the sex, if the sex is for female. So if the point is less than or equal to 1, then you have to give anticoagulants. Plus please remember, this point should not come just only because of a female. If there is if nothing is present but the person is female, you will not start giving anticoagulant because you will say that she is a female, so we get a point of 1. So this point has to come from other areas. Okay. I have already told you which anticoagulant you have to use, at what, and which one to use when. Now there is very important thing, how to calculate the rate in atrial fibrillation, or in cases of irregular rhythm. In irregular rhythm, how to calculate the rate? How to calculate the rate in cases of the irregular rhythm? Now if you see, this is an irregular rhythm. How to calculate the rate? So you have to understand there are two kinds of boxes. One is a large box and other is a small box. Okay. So a large box contains 5 small box, and one, for example, if this is a large box and this is containing 5 small box. So time of one small box is 0.04 seconds. Just remember this thing. Okay. If the rate is normal, that is, if the rhythm is regular, then you calculate 15. Then rate is calculated by 1500 divided by n, where n is number of small boxes. Number of small boxes. Or if you want to calculate with the help of bigger boxes, then you have to calculate 300 upon capital N. That is where n is the number of large boxes. But these values will not work if the rhythm is irregular. There what you have to do? You have to take 30 large boxes. If the rhythm is irregular, you have to take 30 large boxes. You have to calculate number of R waves, and you have to, for example, this R wave comes to be X, then you have to multiply that with the 6, and this will give you the rate. So what you have to do, you have to, in case of irregular rhythm, you have to take 30 large boxes and you have to calculate the number of R waves in those large boxes and you have to multiply it by the 6. Now you have to understand the basic of this thing. So I have told you that one small box is of 0.04 second. So one large box time is 0.04 into 5, that is 0.2 seconds. And we are taking 30 large boxes. So time in 30 large boxes will be 0.2 into 30. That is 6 seconds. So we are calculating actually R in 6 seconds. Now this X has to be multiplied with the 10. Sorry. Okay, that is why you have to know the basics. Okay, now so you have actually calculated the RR over 6 seconds. Now if you multiply it with the 10, it will be over 60 seconds. That means of 1 minute, and the RR number of R waves in 1 minute is the actual respiratory rate. So that is why you have to calculate what you have to do. You have to take 30 large boxes and you have to calculate number of RR waves in those 30 large boxes and you have to multiply it by the 10. So this is the reason, and this is the explanation. So this was regarding atrial fibrillation, and we'll see other like atrial flutter and multifocal atrial tachycardia in the next videos.